Wrist is highly important for a normal function of patient's hand. Wrist is actually a stabilizing force for the normal functions like pinch, grasp, especially the grip and the strength of the grip. If for any reason our wrist is not functioning properly or there is pain, the most problematic portion for the person is actually to grip it and not perform the normal activities of the hand. Therefore, to have a stable and a disease-free wrist is highly important for a person to function properly, because otherwise the hand function would be highly affected. Now, as you know, our wrist is actually made up of 8 bones. That there is articulations of 4 bones in the proximal row with the 4 in the distal row. Proximal row articulates with the radius and ulna, and the distal row articulates with the proximal row as well as with the metacarpals. As you know, in a normal wrist joint, if you see, this is the distal radius portion and this is the ulna. There is a scaphoid fossa of the radius which articulates with the scaphoid. There is a lunate fossa which articulates of the radius which articulates with the lunate. There are 4 bones in the proximal row, that is the scaphoid, lunate, triquetral and pisiform. This triquetral and pisiform may not directly articulate with the ulna, but they are interconnected with intercarpal as well as radioulnar and ulnar carpal ligaments as well. Now, the proximal row is formed by the scaphoid, lunate, triquetral and pisiform. Then there are 4 bones which are actually formed between the it's just actually form the distal row which articulates with the metacarpal. The 4 bones starts right from there, trapezium and trapezoid. Then you have the large bone called as the capitate as well as the hamate which articulates with the metacarpals. Now, in a normal joint, what you need to remember is that these bones are actually, there are intercarpal ligaments, that is, which are connecting one carpal bone with another. For example, classically is the scapholunate ligament or lunotriquetral ligament. Then there are ligaments which are attaching these carpal bones with the radius and ulna, for the radiocarpal as well as ulnocarpal ligaments. And then there are those which are actually attaching these with the metacarpals as well. For example, you have scaphoid which is present in the scaphoid fossa of the distal radius, and there are definitely radioscaphoid ligaments as well as lunate ligaments as well, which are stabilizing the scaphoid in the scaphoid fossa of the radius. Then you have triquetrum and lunate, which are also part of the proximal bone, and they form the ulnolunate and ulnotriquetral ligament. As I told you, there is a radiocarpal as well as ulnocarpal ligaments which are actually stabilizing these wrist carpal bones. There may be a palmar-radioulnar ligament along with the dorso-radioulnar ligament as well. And why this is important? Because this actually forms the main stabilizing force of the disto-radioulnar joint. Extensor carpi ulnaris forms a part of a TFCC, which is called as triangular fibrocartilage complex. And these ulnocarpal ligaments are highly important in providing the stability of ulna towards the lunate and triquetrum. When we look at the distal radioulnar joint, it is actually formed by the sigmoid notch of the radius as well as the ulnar head. Why its stability is important? Because the radioulnar instability can lead to carpal arthritis, and this radioulnar instability is usually associated with certain problems, such as most commonly it is associated with distal radius fractures, which is very common, or distal ulnar fractures, or it could be associated with the TFCC tears, ulnar abutment syndromes, or there may be associated a malunited distal radioulnar fracture. Now, clinical features, if the patient presents with you with a distal radioulnar joint, this could be due to acute symptoms or it could be due to the chronic injury as well. Mostly the patient presents with the painful restriction of pronation and supination. There may be associated with clunking, especially when there is ulnar abutment syndrome, especially when a patient is asked when he or she tries to ulnarly deviate the wrist, there is especially quite painful, or there is clunking which is quite very much audible. Then there is undue prominence of the ulnar head. This may be due to the positive ulnar variance, which may have happened either due to the distal radius fracture, distal ulnar fracture, or there may be associated with S6 leprosity fractures of the distal radioulnar joint or Galeazzi fractures as well. There will be tenderness. Tenderness could be on mostly on the radial side, but it could also be present over the ulnar side as well. And then there is a positive examination test called as piano key sign. When you look at the distal radioulnar joint from the lateral side, there is usually dorsal subluxation of the ulna. And when you press the ulna with a piano key sign like a thing, it goes and depresses downward. This is classically as if you are pressing the key of a piano. And this is positive with the distal radioulnar joint instability. Now when you get an image, the first and foremost, usually you get an AP and the lateral view of the wrist. What do you see over here? If you see this X-ray carefully, radius in the scaphoid fossa, scaphoid looks okay, the lunate fossa looks okay. But if you appreciate, there is definitely no contact of the sigmoid notch with the radius, as this is creating a problem over here. Therefore, an AP view that usually shows increased widening of the radius and scaphoid sigmoid notch of the ulna. And the lateral view, if you see it over here, there's increased dorsal subluxation of the ulna. This is where that is why the piano key sign is positive. And in AP and lateral view, you can appreciate that this definite disruption of the distal radioulnar joint. Now coming to the treatment. Now the first and foremost what is important is to, whenever you have a distal radius fractures, or Galeazzi fractures, or distal radioulnar fractures, anatomic reduction of the distal radioulnar joint is mandatory. Whether if it is an acute phase, you have to pass up a cross K wire to reduce the radioulnar joint. That is important because later on this would lead to distal radioulnar joint instability. But if instability has happened, then there are different modes of treatment. This could be simple splintage and immobilization along with NSAIDs, or it could be multiple surgical options we have. One could be an osteotomy of the radius, or in which the increased ulnar variance is actually compensated, or it could be fixation and bone grafting, that you open reduction internal fixation of a chronic non-union or malunion of the radius along with the bone grafting and fix the ulnar variance there and then. Or we can do as arthroscopic or open methods to actually go for distal ulnar resection and replacement by prosthetic ulnar head, or simply we can go for ulnar shortening osteotomy. Why? Because ulnar abutment syndrome may be caused by positive ulnar variance, which may be causing the distal radioulnar joint instability eventually, which may lead to arthritis. Therefore, the problem is with the ulnar variance. Therefore, the best method is to go for ulnar shortening, and then later on we can fix this ulna with a simple dynamic compression plate. Now coming to the disorders of the triangular fibrocartilage complex. What is TFCC? It is actually a combination of different ligaments, which are ulnocarpal as well as radiocarpal ligaments. They contain a tendon called as extensor carpal and a meniscus humula. These are actually articulation between ulna and the proximal nerve. The disorders of the TFCC can be further divided into two subtypes. The one is acute or traumatic, also called as type 1 injury, or the type 2 is called as the degenerative or type 2 injury. Usually the traumatic type is almost 20 to 30% of the time it's a traumatic injury. With more than 50% of the time it's always most likely the degenerative tears. Usually acute traumatic injury could be further subdivided into, as I told you, it's an acute type 1 injury. Type 1A could be a central perforation. Type 1B could be ulnar triquetral proximal avulsion of the TFCC. This could be associated with the distal avulsion, which makes it type 1C, or type 1D, in which there is also associated radial sided avulsion of the TFCC as well. Now, this is actually more of a clinical orientation. Usually, whether it's acute or a chronic, it presents with more or so similar kind of a clinical picture. If you're talking about degenerative tears, it also called as chronic or type 2 injury. This can be further subdivided into type 2A, B, C, D, and E type. Now 2A is actually TFCC thinning. There is no associated degenerative injury. In type 2, there is associated with its 2A plus chondromalacia of the lunate. In type 2C, it is actually combination of 2B plus there is associated ulnotriquetral chondromalacia and disruption. Then from the type 2D is actually a combination of 2C plus lunotriquetral disruption. And then comes the 2E, which is actually combination of all the 2D plus radial distal radioulnar joint disruption or avulsion. Now this is a further actually classification is based on the arthroscopic imaging and MRI, which has been done to evaluate what kind of an injury and what kind of a treatment is required for the TFCC. So what is the mechanism of injury? The most common mechanism is actually called as the foosh or fall on outstretched hand, which is usually happens when you're falling on an outstretched hand, the forearm is pronated, wrist is extended, and it's slightly ulnar deviated. This is the classical injury which happens when the TFCC can get injured acutely, or the injury may have occurred and eventually it may degenerate over time and lead to degenerative type of a tear of the TFCC. But most commonly the pathogenesis or the mechanism start when a person actually falls with the outstretched hand with the forearm pronated, wrist extended, and wrist slightly ulnarly deviated. This could lead to twisting injury of the forearm. Why it's called as twisting injury? Because the forearm is actually pronated most of the time. And when this happens, the TFCC, which is a triangular fibrocartilage complex, may have increased chances of getting injured, teared, or eventually later on get disrupted as well. Now coming to the clinical features. Usually the most common is there is always history of a traumatic event. There may be a pain which is more common towards the ulnar side, and especially increased pain with the ulnar deviation of the wrist joint. There may be a clicking or especially audible clunk which can be heard over, especially when the ulnar deviation of the wrist is done due to ulnar abutment. There may be associated with instability with the distal radioulnar joint. Now, foveal sign may also be positive. What is a foveal sign? If you can appreciate it in the figure, this is the ulnar sided of the wrist, and this examiner is actually palpating between the head of the ulna and flexor carpi ulnaris. As there is a tear, there will be increase, will be depression or prominence. There will be absent, especially in between the FCU and ulnar head. And this becomes the foveal sign becomes positive. Or there may be associated piano key sign as well. As I told you, distal radioulnar joint instability may be associated with TFCC tears. And when there is TFCC tears along with the distal radioulnar joint instability, this may also produce a positive piano key sign in which the forearm is held in pronation with the distal movement of the ulna is actually the ulna is depressed downward like a piano key, and it goes down towards the volar sign. This is an indicative that there is associated distal radioulnar joint instability. Now, if there is a traumatic disruption, how to diagnose a traumatic disruption? First and foremost, on history, there will be definitely a history of some sort of fall on outstretched hand. There will be pain, swelling, and symptoms of an acute injury most of the time. Usually on X-ray sometimes there is associated fracture of the distal radioulnar joint, or this X-ray may be completely normal if it's isolated ligamentous injury. But if you get an arthrography which has largely been replaced by an MRI, this is what you can usually appreciate. If you see, this is the distal radioulnar joint, this is the ulna, this is where TFCC is supposed to be present. There is increased fluid collection, there is edema, indicative of some form of a central perforation, which is most likely this is type 1A injury, along with increased fallout into the radioulnar joint as well. This is going to be most likely presenting a TFCC type 1A injury along with the instability of the distal radioulnar joint as well. Now coming to the treatment, if we have diagnosed it and we are sure that it's an acute injury, then we can treat it as well. Treatment starts, if it's undisplaced and purely ligamentous injury, we can go for immobilization along with the casting and NSAIDs and rest. But usually it's not always the purely ligamentous injury. As I've just told you in the back one, if you can appreciate it over it, there is definitely ligament is involved, but you can appreciate as well that there is increased widening of the radioulnar joint as well. Therefore, this is going to later on get into distal radioulnar joint instability. Therefore, usually most of the time you need an open and arthroscopic techniques to actually repair it. There could be open repair or arthroscopic repair of the TFCC, or if the extensor carpal narrows tendon is disrupted, we can go for arthroscopic or open extensor tendon injury, extensor carpal narrows reconstruction. Or for example, if it was not treated properly or the patient suffered a minor kind of a trauma and patient did not really worried about the things and eventually it settled down, this may eventually produce some form of arthrofibrosis and eventually which may require arthroscopic debridement so that there is no increased arthritis or pancarpal arthritis which may develop later on. Now there is another term called ulnocarpal impaction and TFCC degeneration. These things actually overlap. This ulnocarpal abutment syndrome, ulnocarpal impaction, TFCC degeneration, distal radioulnar joint instability, they are a kind of there is a lot of overlap between the clinical features as well as the problems which eventually may lead to these things. With degenerative tears of the TFCC, this is usually associated with the positive ulnar variance. Normally the ulnar variance is plus minus 2 mm. That is, this is where the distal end of the radial styloid is, and if you draw a horizontal line right from this level, ulna should be at least behind this radioulnar joint, and if you see, this is where the ulnar level is coming in. This should not be, ulna should not be protruding in front of the radius, rather it should be at back. Therefore normally you should have a negative ulnar variance, but if it becomes positive, what goes wrong is actually most of the load is being transmitted from the scaphoid to the radioscaphoid fossa and then to the radius. As radius is normally the most important bone when we are holding something like a pen, or when holding something with a grip like in form of a briefcase, or any weight we are holding in our wrist joint, the main forces are actually transmitted from the radius. But if it becomes positive ulnar variance, then there would be definitely a lot of shift of forces right from the radius towards ulna, and this can actually lead to ulnar abutment or ulnar carpal impaction, and this is actually continuous impaction can lead to arthritis, which may be an ulnar carpal arthritis, or it could be ulnar radiocarpal arthritis as well. Usually if you see this is actually an MRI and you can appreciate its radius, this is showing a lot of positive ulnar variance. Now whenever you are going to rotate the wrist joint, this ulnar styloid is going to hit this part of the pisiform and triquetral and eventually going to produce pisio-triquetral arthritis and ulnocarpal arthritis as well. Therefore, usually this with TFCC degeneration, there is always associated because the ulna is unstable and it can lead to ulnocarpal impaction. Then if that happens, what is the treatment? One way is actually to repair the TFCC, as I just told you, is root cause of the problem is if it is TFCC tear, then you can go for arthroscopic or open repair if it is possible, or even if it's a chronic injury, then you can go for arthroscopic and open debridement, which can be seen it over here. This is an fluoroscopic view of the operative treatment being done arthroscopically. Or to decrease the positive ulnar variance, we can go for an ulnar shortening osteotomy. You can cut the ulna, remove some part of the bone, apply a DCP so that the ulnar shortening osteotomy can be done. Therefore, the load which was actually shifted back to ulna is now going to be shifted back to radius. Therefore, more load will be transferred through the radius and it's going to as per normal wrist biomechanics. When we are viewing the carpal bones, it actually, as you know, there are two rows. There is a proximal row and the distal row, and there are actually no tendons attached on the carpal bones. There are flexor muscles which are crossing these tendons through volarly. You have flexor tendons such as FTS and FTP, which is crossing like on the volar side. Then you have extensor tendons which are crossing it on the dorsal side. But there are actually no tendons which are attaching it on the carpal bones. So these carpal bones are actually interconnected by strong ligaments, which could be the radiocarpal and intercarpal ligaments. Now this is why they form a kind of an intercalated segment. That is, if something goes wrong with these ligaments, the geometry and the biomechanics of intercarpal and radiocarpal or this proximal row and between the proximal and distal row actually becomes disturbed, and this leads to carpal instability. Now if you view this diagram over here, this is a normal view. If you see it over here, this is the distal radius, this is the lunate fossa of the radius, and this lunar shaped bone is called as the lunate artery, which is part of the proximal bone. This articulates with the capitate, and the second metacarpal articulates with the capitate. So this is part of the proximal bone, this is the distal row, and then the metacarpals. You see, you can appreciate the shadow of the scaphoid, which is actually, when you are viewing an x-ray from the lateral side, you do not see the scaphoid straight away. You can appreciate the shadow behind the lunate. Now there is a term called a scapholunate angle, which can be calculated like this: through the center of the lunate, through the center of the scaphoid, there is usually this angle is between 50 to 70 degree. This is a normal orientation of a scapholunate angle. Now if this is actually the intercalated segment. Now this is the dorsal side, this is the volar side. Now the dorsal tendon, the extensor tendons are crossing like this, and they're not allowing these bones to go dorsally. And the further what is stopping them to go dorsally is actually the intercarpal ligaments as well, and along with the radiocarpal or ulnocarpal ligaments. Now this is what is actually stopping them from going to this. But if this results in a disruption of a ligament, which is very strong ligament, that is called as the scapholunate ligament. Now scapholunate ligament is actually, it has three parts. There is a volar part, which is actually present between the scaphoid and the lunate. It has a volar as well as the dorsal part as well as the proximal part. The dorsal part is more thick and is actually the main restraint to the dorsal subluxation of the lunate, leading to DC. If you see, this is what actually has happened. The scaphoid lunate ligament has got ruptured, or there is actually degeneration, or there is scapholunate ligament injury, which could be acute or degenerative as well. Now what has resulted in that, if you see, appreciate over, this is the radius, lunate is in its lunate fossa, but can you appreciate the capitate has actually gone up? Why? Because there is increased now scapholunate disarticulation. This is due to the injury to the scapholunate ligament. What can it, if it gets, if not treated properly, it can lead to slack wrist, that is the SLAC or scapholunate advanced collapse. Or this could even lead to snack wrist as well, that is SNAC, which is called as scaphoid non-union advanced collapse. Or this could be leading to proximal row arthritis, radiocarpal arthritis, distal radioulnar instability. All this can be problematic associated with the DC. Now what is VC? This is called as, DC is called as dorsal intercalated segmental instability, and that is why I've taken time to explain to you why it is called intercalated segment, because they are attached to each other by ligaments. There is no tendon attaching on the volar dorsal surface. Rather, the extensor tendons are crossing along the dorsal side. The flexor tendons are crossing over the volar side. That is why once if these ligaments get disrupted, this whole biomechanic construct can actually get disrupted and leads to problems. Now, what is VC? VC stands for volar intercalated segmental instability. What is volar intercalated segmental instability? If you see over here, This is actually due to the another ligament which can get damaged or ruptured called as lunotriquetral ligament. Lunotriquetral ligament is present between the lunate and the triquetral. Lunate is the second bone, which is we are counting it from the radial side of the proximal lobe, and triquetral is the third bone. There is a ligament present in between them called as the lunotriquetral ligament. If this gets disrupted, this can result in it has actually also two parts, the dorsal side and the volar side. Volar is actually more thick, and it is the primary restraint of the volar subluxation of the lunate over the triquetral. If it gets disrupted, lunate goes volarly. And if the lunate goes volarly, you can appreciate that there is a zigzag deformity which can be appreciated on the lateral x-rays with decrease in the scapholunate angle. Usually the angle decreases to less than 30, but normal is 50 to 70. In DC, the scapholunate angle increases above 70. In VC, it usually decreases, and most of the time it decreases below the 30 degrees. There is another angle which needs to be measured as well. Now, one angle is scapholunate, other is actually the lunate and capitate angle. This is called as lunocapitate angle as well. In DC, it increases to greater than 20 degrees, while in VC, it increases to greater than 15 degrees due to this zigzag deformity which can be appreciated on the lateral x-rays. So how to make a diagnosis? Diagnosis depends, it starts with the history. The most commonly mechanism which causes actually the carpal instability is fall on outstretched hand, fourth injury. Whenever you get most of the wrist problems are actually associated with the fourth injury, that is the fall on outstretched hand. And what happens is when you are falling on an outstretched hand, usually the wrist is extended, forearm pronated, most of the impact actually goes towards the radial scaphoid or radiolunate fossa. And when this is happening, this may lead to scapholunate ligament disruption or lunotriquetral ligament disruption, eventually producing either the VC or the DC. So we have a Watson test for the DC. What is a Watson test? As you know, that the dorsal is actually more thick of the two of the volar and the dorsal scapholunate ligament. The dorsal scapholunate ligament is more thick and is actually the primary restraints. So what is done during the test is that the wrist is in ulnar deviation. The examiner is pushing from the volar side towards the dorsal because the dorsal is thick, and if it's intact, it's not going to allow the scaphoid to go dorsally. But then the examiner is pushing the scaphoid from the volar side towards the dorsal, and wrist is actually brought from the ulnar towards the radial deviation. And if there is scapholunate ligament is injured, because the dorsal is most thickest part and is most primary restrained, then the scaphoid will move from volar towards the dorsal side, producing an audible clunk. This becomes if there is scapholunate incompetence, Watson test will become positive. Then for the lunotriquetral test, there is actually a ballottement or shuck test. We are testing the lunate. As you know that lunate is the second and the triquetral is the third bone, which is on the ulnar side. The both examiner puts the hand on the dorsal side, and as the volar part of the lunotriquetral ligament is thickest and strongest and primary strength to volar subluxation, the lunate is pressed from the dorsal side, and if that is ruptured, lunotriquetral is ruptured, the lunate will drop volarly and there will be audible clunk, or the examiner can feel the lunate going down volarly. This is actually results in a lunotriquetral ballottement or shuck test is positive. Then a pivot shift test can also be done, but usually this is not required because the most sensitive is the Watson and lunotriquetral ballottement test. Now coming to, once we have a suspicion, we need to be sure whether it's VC or it's DC. And how to get that? There one way of doing it is an AP view. If you see it over here on AP view, you can appreciate this is the scaphoid. There's a large gap in between them, and then there is a lunate. Now this is also called as the Terry-Thomas sign, which is there is increase or greater than 3 mm translation between the scaphoid and the lunate. And this means that most likely on AP view there is disruption of the scapholunate ligament. Now this is most likely DC. So what we need to get is, we need to get a lateral view. And on the lateral view, we need to measure the angle, which is the scapholunate angle and lunocapitate angle. And usually if you get a lateral view and you measure, now this is probably a real-time x-ray which is showing how the shadow actually is seen. If you see that, that was a diagrammatic presentation. Now this is the radius, this is lunate, and this is actually the capitate, but this shadow of this is actually the scaphoid. So you measure this angle and you bisect this line, and this is probably the angle this moment is looking more than 100. Therefore there will be increased scapholunate angle of greater than 70 would be indicative of this is DC or scapholunate ligament disruption. Now if you see over here, now this is showing a different story. Now if this is a lunate and this is scaphoid, if you draw a line like this and draw a line this is actually decrease of scapholunate angle, which is most likely resulting in VCR, lunotriquetral ligament disruption, leading to volar intercalated segmental instability. Once we have made the diagnosis, sometimes we are not exactly sure whether there are different grades of injury. This is mild, moderate, or severe grades. You may need more image intensification. You need to rule out what is actually causing the injury. There may be traumatic injury and there may be associated with scaphoid fractures or transscaphoid perilunar dislocation, or maybe leading to a fallen outstretched hand. Then orthography was previously done, but nowadays orthography has mainly been replaced by MRI. But if you go for orthography, you would, in case of scapholunate ligament injury, you would say increased tie pulling between scaphoid and lunate, as well as disruption of the capsule, which could be seen in the radial scaphoid side. Nowadays mostly we are going for MRI, and usually MRI, if you see, this is showing a scapholunate ligamentous injury with disruption as well as increased fluid uptake and collection over the scapholunate ligaments area. Most importantly is actually nowadays arthroscopy. Arthroscopy is both diagnostic as well as therapeutic. Now if you see over here, this is an arthroscopy which is showing this is a scaphoid and this is the lunate, and a probe is actually being inserted. If you can insert a probe in which is actually at the tip of 3 mm, this means the distance between the scaphoid and lunate is more than 3 mm, and therefore this is definitive that most likely this is a DC leading to scapholunate ligament rupture. So what's the treatment of this carpal instability? Once we have diagnosed it, this is either DC or VC. First you need to be sure whether it's DC or VC, and then what treatment we need to give. Now if you see, this is actually showing an X-ray of scapholunate dislocation, and you can appreciate it over here that this is lunate, this is capitate, and you can appreciate the shadow of the scaphoid, and if you calculate the shadow of the scaphoid and this value, it comes out to be greater than 83 degree, that is more than 70. Now this is showing lunotriquetral dissociation or VC. If you appreciate it over, this is this radius, this is lunate, this is the shadow of the scaphoid, and this is the capitate. You can appreciate it's going more polarly and there's decreased scapholunate angle. Now this may be due to the dorsal malunion of the distal radius. As you can appreciate, this is an old malunited fracture with disrupted distal radioulnar joint. Ulnar styloid is probably non-union as well, and you can appreciate as well that there is probably associated with either lunotriquetral or scapholunate ligamentous injury as well. Now depending upon where it is actually causing the injury, we can go for either initially in acute injury, we can go for immobilization procedures, NSAID and wrist. Then we can go for arthroscopic repair of these ligaments as well. If there is a chronic injury, it may require arthroscopic reconstruction of scapholunate and lunotriquetral ligaments injury as well. Or we can go for, depending upon what is the stage of the disease. If it is involving scaphoid, trapezium, trapezoid arthritis, we can go for STT fusion or even radiocarpal fusion as well, depending upon if it's an acute injury and there is not much of arthritic changes. But if the disease has progressed and advanced to a certain extent, we may go for a fusion procedures which actually although decrease the movements at the wrist joint, but actually rid the patient of painful arthritis. Now coming around to another pathology for the wrist, that is the rheumatoid arthritis. As you know, rheumatoid arthritis is an autoimmune systemic inflammatory disease. It affects multiple joints. Then they may be associated with positive rheumatoid factor and TCCP positivity as well. But if we would be discussing specifically the rheumatoid arthritis of the wrist and the metacarpal phalangeal joint, because as you know, the most common areas of rheumatoid affecting the hand and upper limb is mainly around the wrist and metacarpal. Usually the PIP and DIP are more commonly affected by the osteoarthritis. Now, if you see, this is classical presentation of a rheumatoid hand. There is a zigzag deformity with metacarpal phalangeal joint going ulnarly, with the metacarpals deviated radially, as well as there is volar and ulnar subluxation of the carpal bones. This is classically presenting the ulnar deviation along with the zigzag presentation of the wrist of the rheumatoid patient. Now, if you see, this is an X-ray of the distal radioulnar joint. You can appreciate this periarticular osteopenia with these lytic lesions involving almost all of the carpal bones. There is periarticular erosions as well. You can appreciate this is the subchondral bone which is eroded over here as well as the radial styloid as well. This is classical presentation of the rheumatoid arthritis. It presents with periarticular osteopenia, periarticular erosions, as well as the classical this deviation or ulnar deviation of the wrist joint. As compared to if it would have been an osteoarthritis, there would be decreased joint space, arthritic changes along with the osteophyte formation. But you don't have any such thing in case of the rheumatoid arthritis. Similarly, if you go for more imaging, you can appreciate it over here as well. There is periarticular osteopenia, although there is maybe early formation of periarticular erosions. Now this is showing more erosions and osteopenia around the joint. This is showing end stage arthritis in which there is maybe a partial fusion of the distal radius with the carpal bones, and usually probably the wrist joint is not salvageable. Now, if you have a patient has been diagnosed with rheumatoid arthritis, because then the first is always the pharmacotherapy. Maybe we given the disease modifying anti-rheumatic agents and interleukin inhibitors. But if the disease has progressed, that it is actually resulting in a lot of arthritis, pain and debility and deformity, then we may have to go for internal fusion. As you can appreciate it over here, that this is actually the wrist fusion being done with the radius being fused with the carpal bones with the ulnar head resection, so that the ulnar deviation of the wrist can be restored as well. Now coming to radiocarpal osteoarthritis, although as compared to the rheumatoid arthritis, osteoarthritis affects wrist and metacarpal joints rarely, but it can still affect the wrist joint as well. Usually there is different scenarios. It can present as scapholunate advanced collapse due to scapholunate ligamentous injury, or it can present with scaphoid non-union advanced collapse due to scaphoid fracture and non-union associated with it, or it can be associated with distal radioulnar joint arthritis as well. But depending upon what was the cause, it may present as a radiocarpal arthritis. If you see it on X-ray, there is reduced joint space, as I told you. There is no periarticular osteopenia and erosions, but there's definitely osteophyte formation. If you can appreciate it over here, there's a developing osteophytes. Probably this is also an osteophyte formation on the dorsal side as well. If you look at this X-ray, this is classically affecting the scaphoid. Probably this is scaphoid STT arthritis, that is scaphoid trapezium trapezoid arthritis. There is reduced joint space, there is osteophyte formation, and there is associated with intercarpal arthritis as well. Or this can be treated with STT fusion most of the time, in which the scaphoid trapezium trapezoid is actually fused in one go, so that the patient can be ridden of the pain, although that would definitely compromise some form of a movement to the wrist joint. Now, depending upon what type of problem is it STT wrist, It is SNA series, that is scaphoid non-unit advanced collapse, or it is SLA series, that is scaphoid unit advanced collapse. Depending upon what is the problem, we can treat it. Like if it's a pancarpal problem that is involving all the bones, then patient could be either of two types. It's low demand, old age sedentary style patient, or it could be young patient who has an active lifestyle and maybe a laborer as well. So if it's a low demand patient, you can go for wrist replacement in form of distal radial replacement, or if it's a high demand patient, we can go for orthodesis of the wrist joint or total wrist fusion. If it's involving only the radius and lunate and mid carpal joint is preserved, we can go for radiolunate fusion only. Or if it is involving the radius and scaphoid, then it depends whether the proximal row is involved or not. If the capitate lunate is preserved, that is there is actually isolated radioscaphoid problem, then we can go for proximal row carpectomy or PRC. But if it is involving the capitate lunate, this means first row as well as the distal row both are involved. Therefore, we may have to go for four corner fusion, that is fusing the scaphoid with trapezium and trapezoid as well as lunate with the capitate. Now it becomes a kind of a quadrangular four corner fusion in which the wrist is fused from proximal as well as with the distal row. But if it's isolated radioscaphoid lunate problem only, and mid carpal, that is the capitate, lunocapitate as well as the scaphotrapezoid and trapezium are safe, then we can go for radioscapholunate fusion only. The bottom line of all this graph is that you have to determine whether it's isolated radiocarpal involvement, that is between the first row and the radius, then you can go with the radiocarpal fusion. But if the arthritis has spread up to the second row, that is involving the distal row as well, then either you may have to go for proximal row carpectomy or four corner fusion or even the wrist fusion as well. It's something that is going to treat both the rows at the same time. Now, before going on, this can present, this radioulnar arthritis can also be debilitating and usually is associated with radiocarpal osteoarthritis and can present after the distal radioulnar instability as well. Now it can be treated in multiple ways. One way is if it is simply ulnar head resection, distal ulnar is resected, or if the patient is low demand, we can replace the ulnar with the ulnar head replacement surgery. If that is only in case of low demand patient. In high demand patient, we may have to go for some form of fusion and eventually orthodesis. Or we can go, if it is associated with a malunited or non-united fracture, we can go for ORIF with bone grafting of the radius so that the alignment of the wrist can be recreated along with the ulnar head implant, which can be used for instead of orthodesis as well. Now coming to carpometacarpal osteoarthritis, that is actually involving the first carpometacarpal joint. This has a special significance, especially in the patients with the old age, because actually thumb is very important for opposition and pinch function. And carpometacarpal arthritis can be highly painful, especially when an old age patient tries to hold something like, for example, key or even stove or anything which is any kitchen utensils, that can be highly painful for during the daily activities. Therefore, this carpometacarpal arthritis is involving trapezium, trapezoid as well as the metacarpal, then we eventually would require some form of a fusion for either. We can go for one way out is to go for one of the carpal bones can be resected and later on other can be fused, or we can go for carpometacarpal fusion, that is all the trapezoid, trapezium and metacarpal actually has been fused by use of a screw. Now another form of carpometacarpal arthritis is actually to go for silicone arthroplasty. Although silicone has its own nuisance, it actually produces a very autoimmune and inflammatory reaction, but there was one way out is that you can replace the head of the first metacarpal by silicone implant. This is the bone, this is scaphoid, and you can appreciate over here the carpometacarpal fusion has actually taken place. this trapezoid and trapezium can be replaced by a silicone implant. Now coming to another arthritis which is part of the radiocarpal arthritis called as STT arthritis, or scaphoid trapezium trapezoid arthritis. This involves the scaphoid, trapezium and trapezoid joints. As you know that this is the wrist joint in which the scaphoid articulates with the trapezium and trapezoid. And if this are the arthritis involving this joint, usually it results in the scaphoid area tenderness. There may be associated radial sided tenderness, or this may be associated with the snuff box tenderness as well. And usually there may be loss of sensations over the area of the snuff box. If this is the situation, you can very well appreciate that probably the scaphoid trapezium and scaphoid trapezoid joints are probably gone. The only option over here is left with STT fusion or scaphoid trapezoid fusion, which could be done in one go surgery, so that the patient may have a compromised movements, but patient will be pain free for most of the time. Now another form of radiocarpal arthritis which occurs on the ulnar side is pseudorachitral arthritis. As you know, pisiform articulates with the triquetrium. Triquetrium does not directly articulate with the ulna, but it articulates with the lunate, and a TFCC is actually an interconnecting sort of a bridge which connects these bones together. If this is actually leading to a lot of problem, for example, pseudorachitral arthritis can lead to continuous problems, especially during the ulnar deviation, ulnar sided wrist pain, debilitating ulnar abutment syndromes. Then the probably most common treatment is actually the removal or excision of the pisiform bone, usually which can be appreciated in this diagram. Thank you very much. Keep watching scardia.com.